Hello guys, welcome back to my YouTube channel. Today I am going to discuss about the oculomotor nerve. So, before I am going into detail about this oculomotor nerve, first I would like to give an overview about the functional classification or the what are the motor nuclei and what are the sensory nuclei in the brainstem, because the 3rd to 12th cranial nerves are emerged from the brainstem. It is appropriate to revise the functional classifications of cranial nerve nuclei under um, this topic. When we talk about the functional classification, hope you are clear with this diagram. There are three types of motor nuclei. Here is the motor nuclei, but you can see in this diagram, this in this side the motor nuclei, and in this side you can see the sensory nuclei. So four types of sensory nuclei are there. When we talk about the motor nuclei, only three types of motor nuclei, and they are somatic efferent fibers which supply striated muscles developed from somites, special visceral efferent fibers supplied by striated muscles developed from branchial mesoderm. Then general visceral efferent fibers supply postganglionic parasympathetic fibers to the glands and some smooth muscles inside the eyeball. Then the sensory fibers, the cranial nerves contain peripheral processes of related sensory ganglia. So the central processes of sensory ganglia terminate on the sensory nuclei related to the nerves. Then you will have general visceral afferent fibers, then special visceral afferent fibers, then general somatic afferent fibers and special somatic afferent fibers, which are related to those sensory nuclei. Here then you can see as the sensory nuclei, mesencephalic nucleus of trigeminal nerve, principal trigeminous nucleus, then vestibular nucleus, cochlear nucleus, solitary nucleus, spinal trigeminal nucleus, solitary nucleus of GVA portion and spinal trigeminal nucleus. Here in this side you have the motor nuclei in the brainstem. From the midbrain downwards, you have Edinger-Westphal nucleus, oculomotor nucleus, trochlear nucleus, trigeminal motor nucleus, abducens nucleus, facial motor nucleus, salivary nuclei, nucleus ambiguus, hypoglossal nuclei, dorsal motor nuclei of vagus, and accessory nuclei. In this picture also you can see those particular motor nuclei and sensory nuclei. In this side you will have the motor nuclei, and in this side you will have the sensory nuclei. Here this is the midbrain level. Here the oculomotor nucleus and trochlear nucleus. Here the Edinger-Westphal nucleus, and again here the pons, and here the medulla oblongata. Now we will move on to the oculomotor nerve pathway proper. The oculomotor nerve is the third cranial nerve. It is the purely motor nerve that is responsible for movements of eyeball, constriction of the pupil and accommodation. This oculomotor nerve is also known as the nerve of accommodation. When we talk about the nuclei of origin, you can see this is the origin of oculomotor nerve, and here the oculomotor nerve nucleus. It is located in the periaqueductal grey matter anterior to the cerebral aqueduct at the level of superior colliculi. Here is a cross section of midbrain. Here you can see periaqueductal grey matter, cerebral aqueduct. Here is the oculomotor nuclei. Here you have main oculomotor nuclei and Edinger-Westphal nuclei. Actually, this oculomotor nuclei is divided into two parts, as somatic part is the main motor nuclei and the autonomic part is the Edinger-Westphal nuclei. So you can see both of the divisions here. This is the red nuclei and this is the oculomotor nerve pathway, and here is the tegmentum. Here you have pretectum, and here is the superior colliculus, substantia nigra in the midbrain, and finally crus cerebri are here. So each of these part is important in describing the pathway of oculomotor nerve. That's why I showed you the cross section. Actually, this main motor nucleus of the oculomotor nerve, here is the main motor nucleus. It is main nucleus subdivided into different groups which supply the individual intraorbital muscles: inferior oblique, inferior rectus, medial rectus, superior rectus, and levator palpebris superioris muscles. The Edinger-Westphal nucleus, this one, gives parasympathetic supply to the ciliary and sphincter pupillae muscles. There are two functional components of the oculomotor nerve nuclei. They are somatic efferent fibers arise in the main nucleus of the oculomotor nerve for supply of muscles I have mentioned above. And then the other functional component is general visceral efferent fibers. They that are arise in the Edinger-Westphal nucleus for relaying ciliary ganglion and supply ciliary and sphincter pupillae muscles. When we talk about the connections of these oculomotor nerve nuclei, the nuclei are connected to the corticonuclear fibers from the opposite cerebral cortex and also to the superior colliculus and pretectal nucleus. Here, the vestibular nuclei are connected through the medial longitudinal bundle. In this picture, you can see medial longitudinal fasciculus here. Here is also a cross section of midbrain in the level of superior colliculus. Remember that each of these part which contains in this midbrain cross section is important in neuroanatomy when you describe in pathways of cranial nerves. Here is the red nucleus, and here is the substantia nigra, here is the crus cerebri, and you have the lemniscus here, trigeminal lemniscus, spinal lemniscus, medial lemniscus. Then the cause of the oculomotor nerve, the cause of axons of oculomotor nerve inside the midbrain is called as intraneural cause. The axons of the neurons of the oculomotor nucleus travel in the anterior direction through the red nucleus here and medial part of substantia nigra. When we talk about the point of emergence of oculomotor nerve, it emerges from the ventral aspect of the midbrain by piercing medial aspect of the cerebral peduncle. It appears in the posterior part of the intrapeduncular fossa. When we talk about the intracranial cause of the oculomotor nerve, in its subarachnoid course, the oculomotor nerve lies between posterior cerebral artery and superior cerebellar artery. It is also in close relation to the posterior communicating artery. Here there is posterior communicating artery also. So imagine if there is an aneurysm occur in any of this artery, it can block the nerve pathway or it can damage to the oculomotor nerve. So, such a lesion in the oculomotor nerve, we call them as isolated oculomotor lesion because in this area, the oculomotor nerve goes along. There is no any other cranial nerve goes with this oculomotor nerve in this area. So, if there is an aneurysm of any of this artery, it is responsible for isolated oculomotor nerve damage. So remember that when you are doing clinicals, it is very important. The oculomotor nerve passes through the tentorial notch. I will show you. This is how the oculomotor nerve emerge from the pass through the tentorial notch and then enters through the lateral wall of the cavernous sinus where it lies in the posterior in relation to the trochlear, ophthalmic and maxillary nerves. The oculomotor nerve is in danger of compression at tentorial notch because there can be herniation of uncus and also cavernous sinus thrombosis. So in cavernous sinus thrombosis, this oculomotor nerve can be damaged, but not only the oculomotor nerve damage in cavernous sinus thrombosis. There can be the lesion of trochlear nerve, abducens nerve, ophthalmic and maxillary divisions of the trigeminal nerve as well when there is cavernous sinus thrombosis. Here in this diagram, this is the oculomotor nerve. Here, this oculomotor nerve, you can see it goes through the tentorial notch and enters into the cavernous sinus here, and then oculomotor nerve leaves the middle cranial fossa to enter into the orbit. Here is the orbit area, and it enters into the orbit through superior orbital fissure. This oculomotor nerve, before entering into the superior orbital fissure, it has divided into two parts as superior division and inferior division, or the upper division and lower division. You can see the upper division goes forwards and upwards lateral to the optic nerve and supplies superior rectus muscle and levator palpebrae superioris muscle. This is the lower division which gives three branches to the medial rectus muscle, inferior rectus and inferior oblique muscle. So here you can see the ciliary ganglion here. So the branch to inferior oblique muscle provides a communicating twig to the ciliary ganglion. The communicating twig contains preganglionic parasympathetic fibers from the Edinger-Westphal nucleus. If this is the ciliary ganglion, if this is the nerve which goes to this inferior oblique muscle, these are the preganglionic fibers which coming through the oculomotor nerve, which originates in the Edinger-Westphal nucleus. And then this is when we talk about the ciliary ganglion further. Ciliary ganglion is a peripheral parasympathetic ganglion which is located in the posterior part of the orbit. The preganglionic fibers originate in the Edinger-Westphal nucleus, or here coming through the oculomotor nerve, and then leave the oculomotor nerve through the branches through the branch to the inferior oblique muscle. Then those preganglionic fibers make synaptic contacts with the neurons in the ciliary ganglion like this. They make synaptic contacts here. Then postganglionic fibers coming from this ciliary ganglion, we call them as short ciliary nerves. Short ciliary nerves. Here you can see this is the orange color one is the oculomotor nerve pathway, and this is the ciliary ganglion. These are the postganglionic parasympathetic fibers which are called as short ciliary nerves. Those short ciliary nerves pierce the sclera to enter into the eyeball and supply sphincter pupillae and ciliary muscles. So that's all about oculomotor nerve pathway. Let's discuss what are the clinical correlations, or what happens if there is a lesion in the oculomotor nerve. If there is a lesion in the oculomotor nerve, you can see there is complete ptosis. That means complete closure of the eye because of the paralysis of levator palpebrae superioris muscle. Because you know already the oculomotor nerve supplies to this levator palpebrae superioris muscle. Then there can be external strabismus, which is due to unopposed action of lateral rectus and superior oblique muscles. This area and this area. So there can be external strabismus. Because the rest of the muscles, the medial rectus muscle, then inferior rectus muscle and inferior oblique muscles are paralyzed. Then the patient may experience about diplopia or double vision. Is double vision when the patient looking medially, inferiorly and superiorly, because The muscles which are responsible for looking medially, inferiorly, and superiorly have been paralyzed now. So, patient may experience diplopia when looking at those directions. And also, we can see dilated and fixed pupil if the damage if the damage occur in the ciliary ganglion as well, because you know that parasympathetic fibers coming through the ciliary ganglion to the sphincter pupillae muscle, so they are responsible for constriction of the pupil. So if there is any damage to this ciliary ganglion, those innervation is cut off, and we can see dilated and fixed pupils. So that's all about the clinical correlations due to the oculomotor nerve palsy. I hope you understand very clearly about this oculomotor nerve pathway and clinical correlations. And if you like this video, put a like and comment in the comment section as a feedback. And please subscribe into my channel for more videos. Thank you for watching.